Okay, so yeah, I'm Sufyan and I'm going to be talking about stroke and TIA tonight. I'm an F1 in breast and general surgery at the moment. My first job's in stroke rehab and elderly medicine, and my last one will be in MAU, all at Jimmy's. So stroke and TIA, only stroke's actually mentioned in your scary looking syllabus, and it only is mentioned once, just over in the corner over here. But stroke and TIA exist on a continuum, and they're really interlinked with lots of different illnesses and lots of different presentations that patients will have. So it kind of crops up everywhere, and these are just a select few. There's loads more where it will be involved in. So it's really important to know for your finals and also for clinical practice, because lots of people have strokes. So we'll be going through your curriculum sort of stuff about stroke and TIA, and it's a core condition, so you need to know all these things up there. And then it's also an ACT condition, so you need to be able to do these three things at the bottom. And the lecture will be quite simple. It can be put into a nutshell there. That's pretty much everything we'll be talking about, and I'll just be going through expanding each of those points just so you get more of an idea of it. So, like I said, stroke and TIA exist on a continuum. They're both due to loss of perfusion to the brain. In stroke, that's due to infarction or hemorrhage, and in TIA, that's due to ischemia rather than infarction. Stroke's defined by its persistent symptoms, so over 24 hours, and TIA is defined by symptoms that resolve in under 24 hours. In most cases, those symptoms go away completely in 1 hour. And both stroke and TIA are clinical diagnoses, so you make them by examining and taking a history from the patients. The epidemiology of stroke, okay, so it's very common. 1.5 people per 1,000 people per year will have a stroke, so that's 110,000 thereabouts a year in Britain, and that goes right up to 1% of over 75-year-olds will have a stroke every year, either as a first stroke or a recurrent stroke. So it's very expensive, 7 billion a year for the UK or 2.4 billion for the NHS, and the kind of people that get it are same as people who get heart attacks, so people with high blood pressure, diabetes, smoking, lipids, and then some added ones, people who are in AF, and people have kind of vasculitis and increased clotting, as well as sort of family history and all that stuff. So the principles of stroke are quite simple. Certain areas of the brain do certain things. So if you've got a problem, it will give you a problem in that area, a focal neurology. The brain does stuff. It needs blood to do stuff. If it doesn't have blood, it can't do the stuff. So that means people have a lack of something when they've had a stroke. So they have a negative symptom. And your brain's two hemispheres in the cerebellum. The two hemispheres have different circulation. So you'll get a lateralized symptom because it will just be one hemisphere that's affected by the stroke, or the cerebellum. And stroke itself, okay, most strokes are ischemic, so 85% of them are. And those are either from a thrombus or an embolus, blocking the blood supply to a region of the brain. The rest are hemorrhagic. Those mostly occur in the basal ganglion and brainstem. Important things to think about with those are amyloid angiopathy in the older patients who come with like a year or two of increasing memory problems and onset of dementia, because it will be the amyloid plaques making the small vessels in the brain more friable and more likely to bleed, that could be responsible for their stroke. And also for strokes in the cortex and the cerebellum, they may be due to arteriovenous malformations. And then TIA is mostly kind of acrothromboembolisms that cause ischemia, and then the body gets rid of them fairly swiftly, so the symptoms resolve. As well as we're thinking about the output, sorry I forgot that, the MCA, middle cerebral artery, and the anterior cerebral arteries there that go and then feed off those different parts of the brain. So they give rise to the vascular territories of the brain, with your MCA taking up a large chunk of the brain over here. And if you can remember what happens and where in the brain, so you've got like your motor and sensory cortexes over here, your Broca's and Wernicke's over here, you've got your visual cortex kind of there, emotions and executive functions are up at the front here, and cerebellum your coordinations, fine kind of muscle learnt action sort of things, gait and eye movements and stuff like that, and then brainstem for more eye movements and your cranial nerves. So if the stroke affects one of those areas, it will affect that function and give rise to symptoms that affect that function. So the symptoms, higher cortical dysfunctions, are your visuospatial disorders like your inattention and your neglect. Aphasias can be expressive, receptive, conductive, anomic. It's like you can't name things, you wouldn't know that's a bottle. Well, you know it's a bottle, but you couldn't say it was a bottle, you lose the ability to name things. The big symptom we think of is weakness or sensory loss. Then you get your homonymous hemianopias, decreased consciousness, more with kind of mass effects from a stroke, say like a hemorrhagic stroke. Your cerebellar symptoms, like I went through, ataxic gaits, eye movement disorders, slurred speech, poor coordination. Then brainstem symptoms, so quadriparesis, pinpoint pupils. You can get locked-in syndrome, where patients can't do anything, but their cranial nerves are kind of unaffected, so they can move their eyes. Coma, and then it can also present as confusion, which is one of the big confusing things about stroke presentation, is someone who's just sort of confused. That could be due to a stroke rather than anything else that you might be thinking of. So you can use the symptoms and like your vascular territories to classify the stroke, and we use the Oxford or Bamford classification for stroke. And that involves the 4 types of stroke. It goes through the TAX, PAX, LAX and POX. So your TAX is your total anterior circulation stroke, and that has to have the 3 H's happen all at once. So a hemiparesis and or a sensory loss, and that has to involve 2 or more of the arm, face and leg. Has to involve a homonymous hemianopia, and has to involve a higher cortical dysfunction. The hemiparesis and homonymous hemianopia are contralateral to the side of the stroke, so the other contralateral to the side of the stroke, so on the other side of the brain affected. And the higher cortical dysfunction will either kind of be a visuospatial disorder if it's on your non-dominant hemisphere, or if it's on your dominant hemisphere, it's more likely to be an aphasia or an apraxia. PAX is your partial anterior circulation stroke, and just has 2 of the above, or an isolated higher cortical dysfunction. And that just involves a smaller part of that vascular territory being affected, giving rise to fewer symptoms. Your LAX is your lacunar circulation stroke, and that affects the small lacunar arteries that feed the internal capsule of your brain. And the internal capsule, if you can remember, has the descending motor and ascending sensory fibers running through it, and nothing much else. So you get a pure motor or sensory deficit if that's affected. And your POX is your posterior circulation stroke, so that'll affect your cerebellum or your occipital lobe, giving rise to cerebellar symptoms or isolated hemianopias, which can be what are called not just hemianopias but quadrantinopias, so like one portion of your visual field, like a corner being affected, or cortical blindness, depending on where the stroke happens. And the reason we classify is it predicts prognosis and guides treatment. So if you have a TAX, 60% of people who have a TAX will be dead within a year, and only 5% go on to live independently at home. Whereas PAX, POX or LAX, 60% go on to live independently at home, and there's a 15% one-year mortality. So just going back to that, TAX will just knock out everything here, giving rise to motor and sensory symptoms, or your aphasias or your apraxias. You've got that POX, it will affect your visual cortex, or give you cerebellar symptoms, and like the lacunar infarct will happen like kind of lateral to that and affect your internal capsule, giving you the motor or sensory deficits. So, differentials of a stroke. That's thinking about what else can cause someone to come in with a weakness or cerebellar symptoms or confusion or anything like that. The big one's TIA. Like I said, they're on a continuum. The only way you can tell the difference between a TIA and a stroke is either by a CT or by weighting over 24 hours to see if the symptoms go away. Hypoglycemia can give you kind of all sorts of weird neurology or like weird gaits and confusion, so glucose is important to measure. Migraine can give you a hemiparesis, and you can get a migraine without a headache, so you can get a hemiparesis on its own, and that's just a migraine but without the headache. Todd's paresis is quite common, and so that's in people with epilepsy who, after having a seizure, then go on to develop a hemiparesis, and that will look kind of identical to a stroke. And you can only tell if you get a good history or you know they're epileptic and this kind of thing's happened before. Functional weakness is quite hard to distinguish from stroke because people will come with the same symptoms as stroke, and it's hard to tell. Like with some good examination and sort of good history, you can kind of see it might be a functional weakness rather than a stroke. Another important one is an old stroke with concurrent illness. So someone could have had a stroke which gave them weakness on the right hand side of their body, and they recovered quite well from that stroke, but then 2 years later they go on to get a chest infection or urosepsis or something, and that exaggerates their old stroke and makes them appear to have kind of a new weakness on their right hand side. Tumours can give rise to focal neurology, but they kind of have more insidious onset. Aortic dissection will, from where it starts, will knock out every artery it goes past until it hits your carotid, and then it'll just take out a hemisphere of your brain. So it does cause loss of perfusion to your brain, so it does give you a stroke, but from a different etiology. And then Wernicke's encephalopathy can kind of give you the cerebellar symptoms, and then the ones at the bottom are sort of the less common ones that you might want to think of, so hepatic encephalopathy and all the rest. Now, investigations. As an F1, you will be doing these, pretty much, just that little bit up at the top there. So you'll be getting bloods, and the important bloods to get off people are your usual range of bloods. And then we've got PV, plasma viscosity, or ESR or CRP, as a marker of kind of an inflammatory process or a vasculitis that might be going on and causing the stroke. And then clotting, because you want to see have they got poor clotting and it could be a bleed in the brain, or have they got like a hypercoagulable state going on that's causing them to have a stroke. And then cultures, because they might be coming in with a temperature, or they might have had a preceding infection that's kind of caused the stroke or made the stroke worse. And then an ECG. In the first instance, it's a plain 12-lead 10-second ECG, and you're looking for atrial fibrillation there. And if you want to hunt it down and your 12 leads negative, then you can go on to have a 24-hour take. And if that's negative, you can go on to have a 72-hour take. And that sequence of events happens to lots of people with ischemic strokes. You really try and hunt out paroxysmal AF as a cause for the stroke. Now, I suppose the big one that everybody thinks about for stroke investigations is imaging, so a CT. And that's true. Every person who has a stroke or you think might have had a stroke should have a CT within 24 hours of presentation to hospital. And you want it now if they've come in and their symptoms have only started in the last 3 hours or so. And it's important to remember when you're ordering like urgent CTs that half of them are going to be normal in an early stroke. And the reason you're asking for it is not to find an ischemic stroke, it's to rule out a hemorrhagic stroke, because that will drastically change your management. And then if they presented with a slightly older stroke or kind of the TIAs, you want to go down the MRI route, because that's good for picking out smaller strokes and also picking out kind of older strokes as well when the blood's been taken away from the stroke site by the body. And you also want it for those posterior circulation strokes, because the posterior circulation and brainstem is surrounded by all your vertebrae, so it's got a really thick bony wall around it, which will distort your CT, so MRI is kind of better for that. And then chest x-ray, because pretty much everybody that comes to hospital will get a chest x-ray and probably should get a chest x-ray. Then later on, or for more specific types of stroke, you might want to think about a carotid Doppler if you think it's affecting the anterior circulation, because the anterior circulation came from the carotids, and it might have been caused by a stenosis, a narrowing of those carotids, so you want to be doing a Doppler to look for that. But you only want to do it for people who are going to have surgery, who are fit enough to have surgery. So you shouldn't be doing it on like 97-year-olds with tons of comorbidities that wouldn't be suitable for surgery. You should just be doing it on people who would survive an operation like that. And then if you've got kind of a big stroke, or you think it might have some sort of weird origin, then you might do echocardiography to see if there's any thrombus within the heart that's causing the stroke. Management. So like I said, CT changes management. So it makes you rule out hemorrhage, in which case you go down the ischemic line. And the big thing everybody thinks of is thrombolysis. Thrombolysis should only be done if the strokes happened in less than 4.5 hours previously, and under 3 hours ideally. And it should be done on people who've got a big stroke and a stroke that's not swiftly resolving in those 4.5 hours. And it's important to remember some contraindications, although you won't be deciding what's the contraindication, because there's only a few absolute ones, but the important ones to kind of remember: patients above 80, patients with really high, like 220 systolic or 180 systolic, actually, people with low platelets, people who've had major surgery, people who've had a stroke in the past 3 months, because all those things will make you more likely to bleed if you give someone a load of thrombolysis. And everybody pretty much who has an ischemic stroke will get aspirin, 300 milligrams, orally, rectally, or via NG. And that's actually the only real drug in stroke to treat the stroke is aspirin. And you give that for 14 days. And during those first 14 days, you don't give them any tinzaparin or enoxaparin, so you don't give them prophylactic therapy, because you can turn ischemic stroke into a big bleed if you do that. If your CT shows it's a hemorrhagic stroke, you want to think about correcting clotting. You want to see if they're on warfarin, because if they're on warfarin, you want to reverse that warfarin to stop the bleed from progressing. You only really want to control their BP if it's really, really high, because of a risk of under-perfusing the brain if you drop the BP by more than, say, 20% or so. And again, their blood pressure will be like a senior decision, and that'll be stroke consultants who decides what happens to their blood pressure. One of the most important things you can do is keep them nil by mouth, because stroke affects your swallow, so you don't want people aspirating. So keep them nil by mouth, and because you're doing that, you need to give them IV fluids. You need to keep them hydrated and happy and as healthy as they can be in that stage. And then after you've sort of sorted out those big management decisions, you want the stroke patient to then go on to get some rehabilitation, which will be MDT-led rehabilitation, so occupational therapy, speech and language therapy, and good nursing care to try and see what function they can regain, and also see what adaptations they might have to make as a result of their stroke. And then, I think we've cut off the bottom of the slide, but secondary prevention is the next big thing you want to be thinking about, so preventing them from having any future strokes. And also, if you've had a stroke, it means you're quite high risk of having a myocardial infarction or any sort of ischemic heart disease, because it's got the same sort of risk factors. So you want to be reducing their blood pressure, controlling lipids, good diabetic control, antiplatelets and the like. And then if you do find AF, you want to be thinking about starting them on warfarin. Again, have to wait for 2 weeks after their stroke to do that. And if it's an anterior circulation stroke, think about the Doppler ultrasound, and if it does show stenosis of over 70%, then they can go on to have a carotid endarterectomy. And I can't figure out what that bottom bit says. Oh, need for decompression. If it's a big stroke, if it's ischemic, it can become edematous and start swelling and causing a mass effect in the brain. So you might need to contact neurosurgeons to see if they want to take a bit of the skull out to decompress the brain. And also if it's hemorrhagic, you want to see if it's amenable to any sort of evacuation by neurosurgeons, or whether the vessel that's caused it is big enough for them to consider acting on to prevent stroke, the stroke from happening again or worsening. And complications of stroke, like I said, aspiration, that's where you're keeping nil by valve. And then because you've not given them any low molecular weight heparin, and they've had a stroke and can't move, they're high risk of going on to have a PE. And then, like I mentioned before, hemorrhagic transformation, that big clot can break down and just start leaking out blood. Again, like I said, a big ischemic stroke can go on to become full of edema and cause swelling in the brain. One of the big ones is actually bed ulcers, like bed sores and ulcers, because they're unable to move, have a reduced sensation possibly in one of their limbs, and so can go on to develop pressure areas and get like really nasty pressure sores. And because a stroke happens in an area of the brain, you can then go on to develop epilepsy because of that scarred tissue in that area of the brain as well. And I suppose the big complication we think of as disability, the lasting effect of a stroke, is one of its major complications. And again, future strokes, that's why you try and do all that secondary prevention to stop them having those future strokes. And death is another complication due to any of those above. So TIA, like I said, continuum, separated by 24 hours. It predicts a stroke, gives you the same symptoms of a stroke, plus amaurosis fugax, which is that curtains over the eyes if the retinal artery is affected. And if someone's thought to, or if someone's had a TIA or presents as having a TIA, you want to score them, and I'm sure you've probably heard of the ABCD2 score. It's looking at age, blood pressure, clinical features, yada yada. That gives you a score. It's a high score. They need to be seen in 24 hours by specialists. If it's a low score, it needs to be seen by specialists in a week. And again, you want to do the same sort of investigations if they come in with a TIA as you would for a stroke. Find out why they've had that TIA and what you can do to prevent it from becoming a stroke in the future. And then another one to remember is you don't have to report it to the DVLA, but you have to advise patients that they shouldn't be driving for a month. And if they've had repeats TIAs, they shouldn't be driving for about shouldn't be driving for 3 months. So it's ACTS condition. And TIA and stroke, you don't know which one it is until 24 hours have gone by. So what kind of approach are you going to take if you're faced with somebody who thinks had a stroke? What's the first thing you're going to do? Wash your hands, and then go into airway. And then, like we said, nil by mouth, stop them aspirating. If they've got reduced consciousness, do they need an adjunct or anything to keep them, keep their airway patent? Go on to B, the usual sort of stuff, but looking for specific things. So here for aspiration, any signs that they've got a chest that's not quite so clear and they might have accidentally breathed in something they should have swallowed. Circulation, are they stable as they are? Is their BP through the roof? Have they got access? If not, you want to get some large bore cannula in there, take some bloods, get an ECG. All the basic stuff with stroke. It seems like a scary thing, someone's had a stroke, but it's incredibly simple because you just do the ABCD and then possibly give them aspirin. That's all you actually do. And then D, the good neurological examination to try and identify, have they got a focal neurology, and what part of the brain might be affected by the stroke. And then the big one, don't ever forget glucose. Because hypoglycemia it can make you think it's a stroke, or it can cause all sorts of weird symptoms that will lead you hunting down some weird route, but it's actually just they need a bit of sugar, and that will sort them out. And if you don't do that, then nothing else will really sort them out. So it's really important. Pretty much every patient you see ever in any sort of situation, emergency or like acute situation, glucose. Every single one, pretty much. And then more specific things, kind of your focused history. So what happened, when did it happen, how did it happen, blah, blah, blah. And then the when to refer part is you should always refer. Every single person you think has had a stroke should be referred to the stroke team, or indeed to the BAT team, the brain attack team. And then if you think they've had some sort of mass effect or they've got a bleed going on, you want to get neurosurgeons, just have a look at the CT. They probably won't do anything, but you need to get them to have a look at it. If they're on warfarin, you need to reverse it, and we'll go on to that in a moment. Because you've kept them nil by mouth, but you want to give them drugs, you need to put an NG tube in, and chest x-ray, like I said. And again, see, that's the only actual drug you need to know is aspirin, 300 milligrams, PO, PR, NG. And then control any pyrexia which can occur as a result of the stroke. So, warfarin reversal. Have you ever read in the BNF the guidance on warfarin reversal? It breaks it down into a major hemorrhage, and then there are bands of different INRs in which you do different things. So does anybody know what you do in a major hemorrhage and patients on warfarin? Someone shout clearly. Stop warfarin. Yeah, that's the first thing you should do. Stop warfarin. If it's a major hemorrhage. Yeah. Yeah. Both. That's it. Vitamin K and Oxalex. So vitamin K, 5 to 10 milligrams, slow IV. And that will reverse the effects of warfarin, but over like a few hours. So then you want to give them prothrombin complex, and that's dosed by weights, and it comes on a complex sort of charts where you measure their weights and give them the dosing like that. You have to order it from the blood bank. And for the lesser ones, if they've got an INR of above 8 but no major hemorrhage, you give them the vitamin K, and you can do so orally. And then really anything below that, I think, although you're going to have to check, you just want to stop their warfarin and keep on monitoring their INR and restarting their warfarin when it's within their target range. Okay. So, some slides. Anybody want to, it's going to be simple if they come up on the slide exams. It's not going to be really complex. So it's remembering in your slide exams to be as detailed and specific as possible, and obvious as well. So does anybody want to have a go at saying what this is? Right? Yeah. Or ACA. Like the right anterior circulation. And if you wanted to be less specific than that, you could just, like, starting off with the very basics. Not it's a CT scan, but like more. What does it look like? It's hypodense because it's less dark than the rest of the brain. And then, like, what side is it? It's the right side, frontal portion of the brain. Then the important things to remember with CTs are what's the midline doing? So is there any midline shifts? And then you've got other spaces in the brain which can be squashed. So what are the ventricles doing? Have they been squashed and add them there? Okay. Does anybody know what that is, or this is? Anyone? Yes, so that's it. It's chest x-ray for an NG tube that's gone down the right bronchus, like I said, because there's the carina that's gone in there. So important to look at all tubes and things going into chest x-ray, that are in the chest x-ray, and see where they are, if they're in the right place. And that's important because if it's in the wrong place and you go on to feed someone, you give them like a big load of food into their lung, giving aspiration pneumonia, and that's a never event. That should never ever happen. It was an NG tube looping back on itself. And the last one, anyone? What side's the bad thing on? Okay. And is it less or more dense than the rest of the brain? Okay. And is there any midline shift or anything? Might be a little bit there. And has it affected any other parts of the brain? Which parts of the brain? It's gone into one of the ventricles there, so that would be a bleed. Like I said, with hemorrhages or hemorrhagic strokes, they do mostly occur in sort of basal ganglion area, and going into the ventricles is a sign of them being quite severe. And there's my bibliography, and that's me done for the lecture.